Hello, everyone, and welcome to the Global Tracheostomy Collaborative webinar for the month of August 2019. We're very glad that each one of you could join us at this time from all over the world. Our webinar sessions are sponsored by Medtronic and Smith Medicals. However, please be aware that our speakers are not funded by these two industries. Each speaker will share their own disclosures before they present. Please note that you'll be able to ask any questions that you may want to by typing into the chat box, and the answers will be provided at the end of the session. Today's topic is innovative approaches to using simulation in providing tracheostomy education. As many of you know, that caring for tracheostomy patients can be very anxiety-provoking for all disciplines. And anxiety levels can be even higher for those who encounter tracheostomy less frequently. Fortunately, there are innovative technologies such as high-fidelity mannequins, robotic vests, and robotic bleeding mannequins that are available in the market that we can use to educate clinicians on how to facilitate speech, suction a tracheostomy, or perform a cricothyroidotomy. Education using simulation can help decrease anxiety and improve the competency of the healthcare providers without jeopardizing patient safety. Today, we have a lovely panel of experts from Australia, Canada, and the United States. So we have Brooke Duggan and Sonia Baker, who are both advanced speech-language pathologists from Critical Care Princess Alexandra Hospital in Australia, and also ICU and tracheostomy management services from Royal Brisbane and Women's Hospital in Australia. Even though they're from two different hospitals, they've done some phenomenal work together in the education of speech-language pathologists. We also have Dr. Maria Calandria, who is an otolaryngology head and neck surgery nurse practitioner from the Veterans Hospital, North Carolina in the United States. She also works as an adjunct faculty at the Duke University School of Nursing, teaching nurses on how to provide tracheostomy care. Her talk today is specifically going to focus on how to educate healthcare providers on how to suction a tracheostomy tube. Finally, we have an amazing trauma surgeon, Dr. William or Rob Leeper from Western University in London Health Sciences Center, Ontario, Canada, who's going to share information about another innovative model that he has used to train multidisciplinary healthcare providers on how to perform a cricothyroidotomy in case of a trauma situation or a difficult airway emergency. So the objectives of our webinar are to discuss the use of simulation to educate speech-language pathologists and the structure of the program, and also to discuss findings from their workshop survey, to describe an innovative simulator to educate patients on how to suction a tracheostomy tube, and also to describe the use of robotic mannequin to educate medical students and soldiers on emergent cricothyroidotomy. So without further delay, I will request Ms. Sonia Baker and Ms. Brooke Duggan to speak first regarding the tracheostomy and speech pathology simulation workshop that they have been hosting together.
Good morning from Australia. It's 6 a.m. here, but hopefully the voice won't creak too much at this time of the day. We go to the next slide. So I suppose just a little bit of background to our speech pathology simulation course. So we know that within the multidisciplinary tracheostomy team, speech pathologists play a significant role in communication, in assessing, managing swallowing ability for oral intake, and for saliva management to contribute to decision-making for decannulation. So in Australia, skilled management of patients with a tracheostomy isn't an expected competency for graduating speech pathologists, but the skills are required in the workplace. So it's a competency that must be achieved in the workplace. So what we found in our state of Queensland is that we had no statewide practice guidelines for speech pathologists in the area of tracheostomy, and that led to inconsistent management of this patient group. Training was on an ad hoc basis and often relied on work shadowing processes. There was an inability to provide easy access to consistent and repeatable learning environment and finding available hospital patients. There's limited discharge pathways for this patient group. In our state, often rehab facilities don't take patients with a tracheostomy, and that can result in bed block in our major hospitals. Also, traditionally, patients with a tracheostomy are managed at tertiary hospitals, but now they're being transferred to regional hospitals with tracheostomy in situ. So we did a survey of all the speech pathologists within our state, and they really indicated that tracheostomy management continued to be a very high priority area for training. So we know that there's also a growing body of evidence that supports the use of simulation in healthcare. Simulation allows the participants to experience situations, repeat procedures, and learn by making errors without placing the patients at risk. So a number of years ago, we received funding to do some projects, and we developed our speech pathology guidelines for managing adults with a tracheostomy, and that's a large evidence-based reading resource package. We also at that stage developed our simulation course. So our tracheostomy and speech pathology simulation course is a one-day workshop, and it's designed more at the beginner level of tracheostomy management, and it's for working with adult patients, not pediatrics. So we run TASP in our specialised clinical skills development service, and this is a centre that we have on site here at the Royal Brisbane, and it's an internationally recognised provider in healthcare simulation. And we have pockets scattered around our state of Queensland. So from 2011 to 2015, we had our Queensland Health speech pathologists were funded to attend this. Then from 2015 on, our TASP course became for a more national audience, and it became a self-funded course. It's not a competency assessment, but some facilities have chosen to use their attendance at the TASP course as their part of their in-house competency program. So in Australia, the role of the speech pathologist is guided by our Speech Pathology Australia professional body, but that role may vary from facility to facility. So I guess the learning objectives for the day for the TASP attendants is to look at the role of the speech pathologist in the team and the communication within the multidisciplinary team. It's the role of the speech pathologist in the assessment management of cuff deflation and progression, speaking valve use, above cuff line voicing, and swallowing for oral intake. It's the role of the speech pathologist in the decannulation pathway for this patient group. We look at types and features of different tracheostomy tubes and the impact on airflow and voice and swallowing. And a big focus for the objectives is the practical skill development, and that's via use of hands-on tasks involving cuff management, airway patency screening, speaking valve, and above cuff line tubes. So prior to coming to the TASP day, we send out mandatory readings, which is our clinical guidelines, and then we also send out a quiz a little bit after that. And that's not really for us to assess them on the quiz. We don't look at their results with that. It's more that it's it's a self-learning thing, and it's a multiple choice questions. And it's really just getting people prepared for having the base level of knowledge to attend the day before they apply all those skills to a practical simulation day. So I guess if we look at how the day is set out, so we start with an introduction to simulation in the day, and that's with the whole group of 10 participants. And we discuss how the day will run, how simulation works, the rules and objectives of the day. And they also complete a pre-questionnaire to get a little bit of an idea on their tracheostomy knowledge and confidence levels. Then we have a demonstration simulation session, and that is a single case scenario. And the aim is again to demonstrate and show how a simulation session is run, how the room and equipment is set up, how to seek assistance, and the roles of all the participants on the day. Next, we have a part tasking activity, and that's where you break up into 4 groups. Each has their own facilitator. And the aim of this session is to really just practice those core manual clinical skills at working stations. And these are the ones that they're going to apply during the simulated sessions later on in the day. So that's practicing cuff inflation, deflation, placing speaking valves on and off, etc. They also get to handle the different types of tubes and the speaking valves during this session. So I guess it's a allowing for repeated practice of these manual skills, so they're learning through doing. The rest of the day is looking at the immersive simulated patient scenarios, and this is using our high fidelity mannequins. So this is where we break into 2 groups of 5 participants, and this is for the rest of the day until close time. So we start off with patient A, which is a 3-hour simulation, and then we do patient B, which is a 2.5-hour simulation. So patient A runs concurrently in 2 rooms for the day, and then followed by patient B that runs again concurrently in 2 rooms. Patient A is a little bit more of a basic patient. Patient B becomes a little bit more complex because at this stage people are a bit more familiar with simulation, so they can focus a little bit more on their clinical tasks. Then at the end of the day we finish with close and questions for the day, and they also do another questionnaire at the end of the day on how things have gone in looking at their comfort and confidence levels as the day has progressed. So just looking a little bit more in detail at the immersive scenario. So as I said, we're running in 2 areas concurrently, and each room we have 5 participants, 1 nurse, 1 facilitator and 1 simulation coordinator, our SIMCO. And what we're doing is we're exploring 5 moments in time for that 1 patient journey, from the initial speech assessment to decannulation. So each of those 5 participants manages 1 moment in time for patient A, and then later on in the day they manage 1 moment in time for patient B. So we have a scripted scenario that we try to follow, but we definitely allow a lot of flexibility. The script has been written to make sure we cover all our learning objectives, but if the participant takes us elsewhere with the script, then we have the flexibility to either continue along with the journey they're taking us, or we try to steer them back to the script if we want to really address those learning objectives. And it just depends on that individual participant. So initially we discuss the patient's history, the current status and the plans for the session. Then that's when one of the participants enters the room with the patient, which is a high fidelity mannequin, and with a nurse, which for us is a speech pathologist role playing. In an adjoining room behind a one-way mirror, we have the facilitator and the SIMCO, and they're basically watching the sessions live via a number of monitors. And the role of the facilitator there, who's a speech pathologist, is to guide the session according to the script, altering the script depending on what the participant, where the participant takes it, and also to guide the SIMCO if we are changing the pathway. The facilitator is also responsible for 2 voices. They're doing the voice that's emanating from the patient, so they're doing all the sound effects as well of coughing, wet voice. We have a glass on hand so we can do a nice wet aspirating voice. And then the facilitator is also doing, a sort of a big brother voice. So that's a voice that emanates from the ceiling where the participant can ask questions if it's something that the nurse isn't going to be able to address or if the participant isn't going to be able to answer that question. The SIMCO then, who is a simulation coordinator sitting next to the facilitator, their job is to manage all the equipment. So they're changing the monitors according to whether we want the patient to be dropping their SATs. We don't have a lot of high-tech need for our SIMCO, as the same as some of the big advanced life support or CPR sort of simulation sessions. So our simulation coordinator is doing some things that are a little bit more basic, but it's the things that are happening for the patient, such as dropping their SATs, heart rate going up, changing, they can change the eyes of the patient if the patient is drifting off to sleep, etc. The nurse is doing the normal thing that a nurse would be doing with a tracheostomy patient. They're doing the tracheostomy suctioning and they're doing all the other cares. So they have sort of basic tracheostomy knowledge. So we don't want them to give too much away to the speech pathology participant that's attending the patient. The participant that's come into the room, they basically manage that patient in a 10 to 15 minute session, while the other 4 participants are in another room and they're watching that on a live feed. So the participant in the room is responsible for all the decision making for that session. If they need to ask the nurse questions, they can be asking the nurse questions. If they need to ask other things, they can be asking that of Big Brother, and we can provide that information via the Big Brother voice. After that 10 to 15 minutes, the participant leaves the room, and that's when we have our pause and debrief. So the participant goes back to the group of 5 again, And that's when we reflect on what's happened in the session. We use all our typical simulation sort of pause and debrief, reflective discussions at that point. We try not to provide the answers. We hopefully will get some more responses from the other participants in the group. After that, the next participant volunteers and so on. And so we do that through patient A and then through patient B until the patient's decannulated. So I guess the advantage for us that we found with this, because we have low exposure for a lot of our clinicians across our very large geographical state of Queensland, which Brooke will talk about. But in that one day, that clinician manages 2 patients independently, and they actually manage to watch 9 sessions of other clinicians doing the session. So it's probably a lot more than they would achieve even within a week or a month in their own facility. I'll hand over to Brooke now.
Thanks, Son. We thought it'd be also interesting to share the research that we undertook when we developed this workshop and our learnings over the last few years. As Sonia discussed, patients with trachees require multidisciplinary care, and we know that over the last 20 years, these patients are becoming more and more complex and particularly dependent on competent, knowledgeable staff to keep them safe and to provide high quality care. So Son also discussed the training shortfalls are compounded in Australia by, and certainly across the Tasman, by the low frequency and exposure these clinicians are having to tracheostomy patients. So despite our growing body of literature that demonstrates the benefits of having a coordinated training process, we were finding that the implementation of such a process is complex, and unfortunately within Australia and New Zealand it continues to be quite difficult. So our potential came in the form of human patient simulation, as Son discussed, and so we hoped that we could demonstrate that this was actually a useful workshop for our clinicians in Australia. So our tracheostomy simulation workshop was developed to determine whether clinicians could learn and successfully apply core tracheostomy skills in a series of immersive human patient simulation scenarios. And so we wanted to also look at the clinicians' change in confidence in tracheostomy management and also their perceptions of learning in the simulated environment. So we looked at 48 clinicians that were recruited from our public health service within Queensland to participate in 6 workshops. Clinicians were selected to represent a diverse sample from both metropolitan, regional and remote hospitals, and included clinicians with no prior or low levels of experience. And so we also looked at excluding clinicians if they'd had more than 10 tracheostomy patients managed within the last 5 years, no anticipated work opportunity to work with patients with tracheostomies, or if they had limited dysphagia experience. So then, as Sonia previously described, they completed pre-workshop readings and multi-choice quizzes. They've attended demonstration scenarios, the part tasking stations to develop core tracheostomy skills, and then case-based scenarios, which included, as Sonia described, discussions, immersive simulation assessment sessions, and then post-session debriefs. To evaluate clinicians' acquisition of manual skills, performance of core skills during scenarios was assessed by independent raters, and participants completed pre, post and 4-month post questionnaires to look at perceived outcomes, benefits and their feeling of learning in this environment. And then the other thing we also gathered was how much exposure they'd had post this training. In the observational findings, 97% of clinicians were actually able to successfully perform these manual tasks, even with their low experience or exposure to patients with a tracheostomy. In the clinicians' perceptions of the simulated learning environment, there was a significant difference between the participants' ratings pre, post and 4 months post. They were generally quite high pre, but what we found was a significant increase in the positive perceptions of this learning environment, which is a really new thing for clinicians, certainly in the world of speech pathology. Clinicians reported that pre-reading material, simulation demonstrations and the part tasking stations were certainly very helpful in preparing them for the subsequent simulation scenarios. Unfortunately though, we found, that 4 months post, only 79% of the cohort had actually managed 4 or more patients with a tracheostomy. And of those clinicians, only 45%, actually there was actually 45% that hadn't actually come in contact with a patient with a tracheostomy. So the findings from our study certainly validate the use of simulation as a training method and supports our ongoing use of it as part of our competency training within Queensland. Since that time, we've gone on to develop, to open up our workshop, as Sonia described, to both our national and local international colleagues. Within our workshops, within our own workplaces, Son and I have certainly used simulation as a clinical training method to meet the needs of both novice and more advanced clinicians, and to focus on the development of skills, say when we've introduced new tubes, or for non-technical skills, such as working on communication with our multidisciplinary team members. We continue to find that clinicians who work in clinical settings where there are limited numbers of patients with tracheostomies continue to face issues with maintenance of core skills, clinical reasoning, and of course, confidence. We are still collecting our pre, post, and 4-month questionnaires, and we're still finding we're getting a mix of clinicians from, thankfully, both Queensland and across Australia. Clinicians generally have about less than 6 years of clinical experience that are attending, and we are still targeting clinicians with low or no level or no exposure to tracheostomy patients in their workplaces. Confidence remains high, but the limitations, as we've said a few times, continue to be reduced exposure to training. Dr. Anna Miles, a colleague of ours from the University of Auckland in New Zealand, recently reported on her work in this area, which sort of follows on from our work with Dr. Liz Ward. Dr. Miles' evaluation of simulation-based tracheostomy workshop for speech-language therapists. She targeted both adults, clinicians working with adults and children in both urban and rural settings. And in addition to her pre-reading material, quiz, part tasking stations and simulation scenarios, Dr. Miles and her colleagues addressed some of the limitations that we found in our study and have included online theoretical training packages, online videos with examples of practical skills, and then conversations from the simulated scenarios, which they've reported provides that just-in-time training, so that clinicians can return to their clinical settings and then go back and refresh themselves. It's reported that clinicians are using these, and the hope is that it might overcome that decay and that confidence in low level of exposure to tracheostomy patients once they return back to the workforce. Our study also suggests just-in-time training could be useful through the use of human patient simulation mannequins in the workplace as a refresher training course, and using low-cost simulation options and the videos that might be the solution for our colleagues both in Australia and New Zealand that continue to face that limited exposure. So fortunately, our workshop continues to be well received, and with the addition of online training packages and the videos that our colleague Dr. Miles has introduced, mentoring and potentially telehealth, we can hopefully close the gap between skills and confidence of our rural and remote clinicians and ensure that patients receive high quality healthcare services from confident and competent clinicians.
Thank you, Sonia and Brooke, for that lovely presentation about how you put a standardized and structured program together to educate speech and language pathologists. And it seems like it's not just for those within your institution, but you've actually opened it to speech language pathologists throughout your country. That's just amazing. So thank you. At this time, I'm going to invite Dr. Maria Calandria to share about her project that she's been doing to educate nurses on how to provide or how to do tracheostomy suctioning.
Thank you, Dr. Pandian. Hi, everyone. I'm excited to be here from North Carolina and talk to you about the AV Trach, which is a wearable simulated tracheostomy device that we've been using to educate nurses on how to perform tracheostomy care. The study, I have no disclosures to report, but this study was funded by the University of Delaware. So simulation is being used by many high-risk professions. It's used in aviation, it's used in healthcare, and the Department of Defense, which we'll learn more about after this talk. The goal is to simulate real-life experiences and situations, testing knowledge and critical thinking skills, and how they translate into action. Simulation makes students active participants in their learning. The use of the high-fidelity manikin or the current standards in which lack some real-life experience. We also use the standardized patient, which offers another method of education, but there's really nothing out there that simulates real lifelike care of the tracheostomy patient. It is believed that exposure to low to moderate stressors and stimulation provide the healthcare provider with an opportunity to develop resilience and stress, to stress and improve self-efficacy and stress management. The AV-kin was developed to incorporate the lifelike experience using innovative simulated technology to allow the learner to assess, to do tracheostomy suctioning. So the purpose of the study that we're doing is to compare educational benefit using the AV trach compared to the high fidelity manikin. Decrease stress levels by preparing the healthcare provider using simulated scenarios, and improve current educational methods to better prepare nurses and students to perform competent tracheostomy care. The AV trach combines simulation using standardized tracheostomy, providing the learner with lifelike experience incorporating the human factor. And this study may lead to reform in nursing education by including the human factor in training nursing students. So as you see here, current practice on learning these, learning tracheostomy skills are on these plastic mannequins. I remember when I first learned how to do tracheostomy skills, I used the manikin on the right, and then I went into to suction a real tracheostomy patient, and it scared me because they started coughing violently. So this situation really doesn't prepare the learner to adequately, care for the tracheostomy patient. So the AV trach simulates wearable technology, which allows the learner to properly assess breath sounds. It has remote controlled breath sounds in the chest plate. It also allows the learner to suction the trach. It has the ability to put in mucus, which are different colors, and when the learner is suctioning the tracheostomy, they can see what type of the tracheal suctioning, and the simulations will lead the learner to do certain actions related to that mucus, and also perform tracheostomy care and management. One of the things that this AV trach has is if the learner goes in too deep, it vibrates the straps, which allows the standardized patient that's wearing this to, it cues that standardized patient to cough violently because they've gone in too far. So we're going to see a video so that you can see how the AV trach is being used.
AVKIN, a truly human experience, introduces their first product, AVTrach, extending the use of standardized patients and authenticity and high-fidelity simulation. The vibrating straps cue the patient to respond to their care in clinically accurate ways in real time. Knowing the importance of assessment and reassessment, AVTrach is equipped with a variety of lung sounds remotely controlled by an app. The simulated mucus expands the learner's experience by highlighting the sight, feel, and sounds of genuine bedside care. In conclusion, AVKIN has bridged the gap in simulation by putting the patient at the center of the debriefing process. For more information, visit avkin.com.
Okay, so that was a pretty real to life what we're doing in using this simulated tracheostomy device. And we're getting a lot of positive reviews from our learners. So to talk about the study, where the design is a randomized controlled translational study, and the study is being conducted at Johns Hopkins University and the Durham VA, which I am currently at. The inclusion criteria for us in Durham is nurses, novice nurses, and nurses who have not suctioned tracheostomy patients often and they don't feel comfortable. Within Johns Hopkins University School of Nursing, they're using nursing students and other allied health professionals. The exclusion criteria are those practitioners or students or nurses who've suctioned more than 3 times in the last 12 months. The sample size that we have, 70 participants. And the outcome variables that we're looking at is the tracheostomy suctioning competency, which is measured by the tracheostomy suctioning competency checklist. And we're also looking at stress levels of the participants using saliva, cortisol found in saliva samples. So the preliminary data, there's not enough power reached to determine whether the saliva samples indicate statistical significance. Currently, we have about 31 participants and that are enrolled in this study. There are 18 in the interventional group and 13 in the control group. What we have found is that novice nurses trained using the AV trach and the high fidelity manikin both improve from session 2 to 3. So you see the study is being done in 3 phases. Phase 1, we're doing a baseline cortisol or saliva sample and signing consent. In phase 2, we're having the participant suction they're being randomized to the AV trach versus the high fidelity manikin. And throughout their suctioning of this, wherever they're randomized to, they are, we're measuring their cortisol level throughout. And then phase 3, which, or session 4 here is where they're going to an actual tracheostomy patient and we're measuring their cortisol level and their competency. So as you can see, there's an improvement between the competency scores between session 2 and 3. Novice nurses that were trained on the AV trach had a smaller drop in scores in session 4. So the conclusions, the training with the AV trach appears to improve tracheostomy suctioning skill retention more than the traditional high flow simulated, high fidelity manikin simulation training. And the AV trach provides a more effective training tool to ensure proper tracheostomy suction by inexperienced providers. Now the limitations, the study obviously is still in progress. We only have 31 participants. We have more participants are randomized into the interventional group than the control group. And the length of time between training sessions and clinical sessions, so between session 3 and 4, have varied between participants. I also use this to go to the floor from time to time for to train the nursing staff, and I wear the simulated device and have the nurses just go ahead and suction me, and because they don't feel comfortable suctioning a tracheostomy patient, and they really have grown in their skills. They've improved tremendously. We've been doing some simulated events on how to triage respiratory emergency, whether patient has a decannulation, what they're going to do, how to recognize a decannulation or mucus plug. So it's really been a great way to provide education to nurses instead of using the tracheostomy head. Thank you.
Thank you, Dr. Calandria. It's really interesting to hear that you did not only use it for the purposes of research and to generate new knowledge, but you're also using it in your clinical practice for just-in-time training and also to prepare healthcare providers. So thank you for sharing your experience. At this time, I'm going to invite Dr. Rob Leeper to speak to us about the novel manikin that he's been using to educate healthcare providers.
Thanks, Vincia. Yeah, first of all, thanks for the invite. I know we're supposed to declare our biases or our kind of disclosures, and I guess the study was funded by the Henry Jackson Foundation, but as Vincia mentioned, I received no sort of honorarium for talking. Just to think that Vincia was so hugely helpful for me in my training that I would talk for her whenever. I won't always be right on time, but I'll definitely be happy to speak for her whenever. So yeah, that's the nature of this talk. So go to the next slide. So yeah, so I kind of broke this talk down by the problem, and the problem that we're talking about here is the fact that compromised airways cost soldiers' lives on battlefields now and probably through history. A good number of combat deaths are from airway loss. It's the #2 cause of death in combat, behind hemorrhage and tension pneumothorax. And a small but real percentage of patients who require airway management in combat require cricothyroidotomy. So the question was, how do we train novices to do these crics? In the setting of military trauma, we're talking about field medics doing cricothyrotomy. There's not a problem you can bring back to the hospital. Not a doctor doing this. This needs to be a very much novice, care by buddy sort of situation. And so the question is, how do you best get a very novice provider trained up to do the procedure? The two sort of common ways that people have looked at this in the past is either to use an anesthetized or a freshly euthanized animal model, like a pig or a goat, or to use a high-fidelity human simulator, a true, what we call a sim manikin would be the more kind of colloquial term for that technology. Go to the next slide. So the study that was designed, and it was one that was driven by the military. Mark Boyer from the military, working in Washington, D.C., came to Vincia and Elliot, myself, Dr. Hout at Hopkins, and said, what we'd like to do is get a group of novices and train them variably, randomize half the group to being trained on an animal model, half the group to being trained on a standardized stationary manikin, and then bring them to an assessment with, in this case, a moving sort of dynamic manikin and a cadaver, and then score them utilizing some tools that had validation evidence from literature, namely the OSAT score and the Tactical Combat Casualty Care score, to see if training with one or the other produced superior outcomes in these novices. So the novices we chose were medical students. They met the criteria of being very much inexperienced with surgical techniques and airway techniques, and they were all from Hopkins, where I was working at the time with Vincia. And they were all relatively available and happy to have some extra training and get involved in the project. So we recruited a total of 50 students. Go to the next slide. And we exposed them to the following scenarios. So for training, the students were first met by me and Vincia. They went through a little didactic talk and a lecture based on a PowerPoint/video that Mark Boyer put together. So they all had kind of a general introduction to what cric was and why we do it. And then half of them were trained on a recently euthanized pig model, and the other half were trained on a non-moving manikin. The gory photograph you see there is the actual manikin that we're talking about, and we'll show a video to give you a sense of even how much worse it is in real life when he's moving and bleeding. Oh, should I go back one slide, Vincia? Sorry, it's okay, but looks like the video is coming up now. And what I wanted to mention was that in the assessment phase, we did both assessments. One was on a cadaver, a human cadaver, and the other one was on the manikin, but moving and bleeding. So you can see, if you'll cut to the videos now, you'll see what he looks like when he's actually moving and bleeding, which is pretty impressive. show, which is just one of the 50 or so videos that Vincia and I made over the years this was being done in Baltimore. And you'll just see a medical student with his polo shirt on in the background doing the assessment phase of our study, where he's actually being recorded and being given sort of standardized scripts and working through doing the cric on the mannequin. On my screen, the video is still frozen, but
palpate trachea, find the cricoid membrane, make a vertical incision. Then, once you have the vertical incision, make a small horizontal 1 centimeter incision in the membrane. Insert the scalpel to open the airway. Then use the tractor to maintain the airway while I grab the tube. Insert the tube into the airway. And once it's in the airway, pull out the stylet. Plate the tube. Once the balloon's inflated, we'll just secure the airway. Secure the airway.
that was the study design. I'll go to the next slide now. And what you can see is that, go to the next slide. There you go. So this was the actual flow diagram. You can see we do well. We had 50 that we enrolled, 2 dropped out early. And then of the 48 we had, we've divided into randomly to the 2 groups to train on either pigs or the mannequin. You can then see, unfortunately, we lose participants rather in the assessment phase. Believe it or not, med students are nervous, and a lot of them didn't want to come back for assessments, or I think more realistically, a lot of them moved away, finished training, and weren't available at the time that we had cadavers available to be tested on. And so we actually had only about 25 participants finish the full assessment, and that was a group that we actually analyzed. Go to the next slide. So this is the first outcome you can see. I'll explain it. So the blue line is just participants who were trained first on the pig, and the dashed line is students who are trained first on the mannequin. You can see on the left-hand side, their cadaver scores are nearly identical. On the right-hand side, their robotic mannequin scores during the assessment are nearly identical. Go to the next slide. So this is just, again, the complete sort of visual abstract for our paper. We had 48 participants, of whom only 25 finished the study. But when you analyze those 25 on the intention to treat analysis based on whether they were trained initially with a pig or with the mannequin, there's absolutely no difference. Their total time on average was either 155 seconds or 151, identical time frame to get a trach in. Their scores on both the OSAT, and I showed you the TCC score on the last slide, were near identical. The success rate was high, so 82 and 100% of patients, participants rather, were successful in doing the cric, which is, I think, is good news. It shows that both techniques are valuable, but certainly hard to make an argument for one over the other on that basis. So our conclusions were pretty simple. Given there's no difference at all between the mannequin and the pig, a mannequin is less expensive, it's more ethical, and probably easier to transport and store, although Vincia and I certainly had a lot of fun finding homes for the mannequin in Baltimore. So my final thought from this paper that we'll be talking about next month at AAST in Dallas is save a pig and buy a mannequin.
So thank you, Rob, for sharing your experience using this novel device to educate all the practitioners. I know that you didn't do this just for the research, you used it for your simulation and ED as well, right?
Yeah, I had the best time. I picked up this mannequin from Mark Boyer in DC, and we owned him for a year or two. So I used him for everything. I would bring down to the Emerge and run in situ sims. I had recordings of all kinds of our nurses and RTs and docs doing group sims on this. A pretty, you know, if you're in the world of education, you're all used to the Laerdal and the Gomar products for simulation, and they're pretty stationary. When you see a guy who sprays blood, turns his head, and moans at you, it actually, like, it really, we had our providers were like were caught off guard by how realistic he was, and it adds that element of you know, tachycardia that we all get during medical care, especially urgent medical care. And I think it lent a lot. It made the sims a lot much more powerful, and we had him versus the standard commercially available products.
Mm-hmm. And I know that Maria had a very similar experience as well, even though tracheostomy suctioning is not as stressful as performing a cricothyroidotomy when you don't have an airway. We actually find that our nurses have tachycardia as well. Our speech language pathologists have tachycardia as well when we have to suction them and open up the airway so that the patient's oxygen saturation can improve from whatever is causing, from the secretions that are causing the obstruction. So I want to take this time to thank each one of you for sharing various innovative approaches to educating healthcare providers on how to care for patients with a tracheostomy. And I personally think that a lot of what we've been doing to learn or using for healthcare providers is actually translatable for education of patients and family members as well. So this time I'm going to open the time for any questions that the audience may have. I'll be reading the questions that you've written so that we can await our experts to provide their responses. So far I am seeing a couple of questions come through. The first question is, what test tool is used to assess the knowledge prior? And this is from Meredith Baker Rush. I'm not sure which speaker this question is directed to. Is this for Sonia and Brooke or other folks? So I'll wait for Meredith to respond. Oh, the test tool is for the speech language pathology study. So Sonia and Brooke, can you share what test tool was used to assess the knowledge prior to the simulation?
So we had they read all the readings. So it's a 150 page document that they read on tracheostomy management and speech pathology management in there. They do this online quiz, which is about, I think maybe 30 multi-choice questions. We don't look at those responses. So we don't actually assess their knowledge base. We've put an expectation onto the participant. We know that they're at a basic low exposure level. So we put a little bit of the onus on them to have read the document, done the little self-quiz that corrects them, and if they don't pass it, they go back and do the question again. So we sort of expect them to come with the knowledge, at least, of what they have read in the document, because that is then what they're going to apply to a clinical situation. So it's not so much an assessment, if that's what the question was referring to, versus the pre-questionnaire that we do is more things like where they do on the day is their confidence levels, their exposure to tracheostomy, their exposure to tracheostomy training. So that's more what their comfort and knowledge base about tracheostomy is. I hope that answers the question.
Yes, and I think there's a follow-up question from Gary Wong. He is actually requesting, saying, can we get a copy of the scripted scenario? So Gary, if you don't mind emailing one of us at GTC, we'll definitely be willing to share. I don't know, Sonia, I don't know if it's copyrighted or you're happy to share the script with them.
Happy to chat about it.
Wonderful, wonderful. And then we've got a comment from Kyle Brown. Excellent presentation, thank you. Maria, where are you getting your standardized patients from?
So one of our simulation nurse educators has a contact. I'm not sure where she's getting them from, but she gets them for us through, I'm not sure if it's from a company or what, but I could find out that information if you'd like.
Mm-hmm.
I know the School of Medicine and the School of Nursing here at Duke uses standardized patients, so I don't know if they get them from the same pool of.
Mm-hmm. But since the study was a multi-institutional study, we did it at Hopkins, and we had a pool of standardized patients that both School of Medicine and School of Nursing use, and that's where we reached out for these standardized patients. And at the School of Nursing, what we found was that using the same standardized patients really helped. So whenever we were enrolling participants for the study, we would put the call out and work with those pre-trained standardized patients. So because we have like more than 100 standardized patients in our pool, and it would be very difficult to educate new people every single time. So we brought the same people back if possible. And then I have a question again for Sonia. Could you share with us what was included in the pre-simulation mandatory readings? This is from Arwen Jackson. I'm assuming you're going to be willing to chat with them about that as well.
Yeah, so absolutely happy to chat. It's a document that we were funded to develop early on. Gosh, this is going back 8 years, and then we revised it about 4 years ago. So it's a, I'm trying to think, 120, 150 page document, and it goes through how a trachea is done, how it changes the physiology, the role of the speech pathologist. It's actually quite a recipe cookbook that you could pick up these guidelines, stand next to a patient and follow the step-by-step of cuff deflation, digital occlusion to test for screening of airway patency, speaking valve assessment, swallowing assessment, blue dye use, the validity and safety of blue dye use, that sort of thing, and swallowing assessments. So yes, it's a very, very lengthy document, but it's basically what we use within our state of Queensland. So it sort of talks a lot about how we practice in our state. However, we have all the evidence behind it, and then we talk a lot about some things might be very much facility guided. So things such as spigoting and use of blue dye, they're a little bit controversial in the world of tracheostomy management. So we will have what the evidence says in this document, but then we will say you will then need to find out from your facility what is actually the protocol and acceptable there. So I'm certainly happy to chat to people. Brooke, did you want to add anything else onto that?
No, thanks, Son.
Wonderful. The next question is for you, Rob. Dr. Leeper, what moving manikin did you use?
What's that?
What moving manikin? I think they're trying to get the brand name.
Yeah, the company is called Operative Experiences. You could see them on, I think, a minute or two there on the video they had of the soldier being dragged around. They are a company based in Bethesda, Maryland, right near Washington, D.C., and they work heavily with the military. They make great products. And I will tell you, a mannequin like that will run close to $80,000 or $100,000. But when you look at how many times you can use it versus all of the animals that have to be, born, fed, housed, and grow for training in any number of providers, it actually is much cheaper in the long term, even the medium term, over using animals for training.
Thank you, Rob. There's another comment from John Conrad, and I think this is directed towards Maria. I witnessed the simulator at AARC Summer Forum this year. It was a great learning experience. And there's a question from Gary Wong. Maria, are the respiratory therapists and speech language pathologists involved in the decannulation process? I'm wondering if they're talking about the suctioning process for the study.
So we did not include the respiratory therapist or speech language pathologist. However, we have a trach committee that's an interprofessional committee at the Durham VA, and they are very involved in this committee and in the education of our staff. So we have had nursing blitzes, which I'll go to. I'll bring the simulated AvTrach, and our respiratory therapist runs a little session and the speech language pathologist talking about Passy-Muir valves and laryngectomy. So it's a very coordinated effort in the education. I hope that answers your question.
Thank you, Maria. And there's another comment from Meredith Baker Rush stating that they use a pool of standardized patients for tracheostomy simulations, but they focus their recruitment to a core set who go through extensive training so that there can be consistency with the education process. And then there's a comment from Arwen Jackson saying that the whole thing has been very helpful. Thank you. So thank you everyone for joining us. I think that's the end of all the questions that I can see up here. I do want to thank all our speakers who are experts in their own area. Thank you for making the time to join us. I know it's like 6 in the morning in Australia, and for those of you who are in UK, it's probably close to 10 p.m. at night. So we really appreciate you joining us. And I've put down the email contacts for our speakers. So if you want to take a quick shot of the screen, it might be helpful for you to connect with them directly for any of your follow-up questions. And also please note that a link to the webinar, to today's webinar, will be sent out 10 to 14 days after. And you can review the webinar again, or you can also share the link with colleagues who were unable to attend but would benefit from this session. And remember, we are going to be having our 5th International Trach Symposium in Melbourne, Australia on the 11th of October. So for those of you who have registered already, great, looking forward to seeing you there. But others, if you haven't registered and you're still interested, please do register at your earliest convenience. We typically do our webinars every other month, so ideally we should be doing a webinar in October, but since we have our Tracheostomy Symposium in October, we've actually postponed our next webinar to November. So the date and time is yet to be determined, but the talk is going to be surrounding management of the tracheostomy stoma, and it's going to be moderated by Dr. Linda Morris. So please do join us. We will be sending out information about the upcoming seminar. And thank you again, and see you all in October in Melbourne at the International Trach Symposium, or we'll join via the webinar in November. Thank you, everyone.
Thank you.
Bye.
Thank you.